thanks to Jessica, and it was Jessica's idea that we have a portal in our computer system. We have a statewide computer system that all of this data is collected, and the providers actually are able to enter all their dictation, all that into that computer system. So anytime you call DSS, especially if you're a mandated reporter like a school, the DSS worker could look in the portal and see what's going on. Another risk factor is how many cases that have been previously on a family. So if you've got information, and definitely the intake worker needs to take that information, look at it, and see if it's something that would turn into a report. There's a difference. If you're calling with just information that will help the case, that's different than something that's really a whole new allegation about something that's going on, or additional information that might make it into a report or into a safety issue or a high-risk issue versus just some more information. In other words, if somebody's showing up with bruises and things like that at school, then certainly that needs to be taken as a new report if that wasn't, and whereas if they're just hanging out with somebody that's not somebody they don't need to be hanging out with, or something like that, that's just some information that would be good to have, but not something that would go into another report. So we want to make sure that, especially for your mandated reporters, that the intake workers do take your information and look at that very seriously and look at that through the risk matrix and the safety questions to make sure that it is not something that needs to come back to DSS. We have had those reports or that information that has come to us, and then we have actually asked the provider to send those cases back to us because of the new information. So that I just wanted to kind of make sure we didn't get where you felt like you couldn't call us and we wouldn't give you a good answer. If you're not getting a good answer, you need to let county director know, and if they don't give you, then let me know or Jessica know or whatever, because we want to make sure we keep kids safe. That is, as Teresa said, that is our #1 goal in all of this, is to make sure that children are safe. All right, so a lot of the questions that came up were about really implementation. We're going to talk about data, but I feel like you can't talk about data without also talking a little bit about implementation. And the data the implementation that we used was the NERN, the National Implementation Research Network. When we first started, Jessica said that I was the NERN guru. I said, that's too close to nerd guru, so, you know, I'm not sure that's the title I want to have. So anyway, yeah, so we came up with senior consultant, which is even, you know, I don't know. They couldn't figure out what I do, so they just started giving me all kinds of titles. So anyway, she got the remote. How can a female get the remote? I mean, come on. There's got to be some sort of protective factor there that the males get the remote, right? So anyway, all right. It's getting late. I'm getting slap happy. All right. So, all right. So for AR implementation, you saw today. I think they said 78% of cases reported to CPS for neglect. In South Carolina, last year was 71%, which is pretty consistent, really. 70 to 80% of CPS reports are of neglect. That's shocking to some people. Now, there may be some other things underneath that neglect, like substance use, things like that. Jessica and I both used to be substance abuse counselors, not substance users. Yeah. So we talked a little bit about some of it, and it was kind of a dance our first presentation because we weren't exactly sure what Keontae and Katrina were going to say, and we didn't know exactly what they were going to say this morning, so we've been kind of dancing around. But many of the unfounded reports need services, but they didn't rise to the level of DSS intervention. We know that they have varied services. Like I said, there wasn't a structured case management system. That is something that communities have all struggled with. When I went to Spartanburg as county director for a little while, they were trying to come up with a way to have a case management system. Also trying to connect people with a medical home and let that be the case management system so that everybody didn't end up in the emergency room. So that's a struggle for all communities. And of course, we talked about gaps in service. So we're going to talk now a little bit about the implementation. When you implement a project, I don't know how many of y'all have actually implemented a big change in your system? Well, raise your hand. All right. It's not always easy. You get a lot of resistance, right? A lot of people don't like the change. A lot of people don't like change. And there's some actual science behind implementation. We try to use this science as much as possible. And we're actually going to use this science on another project that we're working with Citizens Trust. So we're all going to be NERN gurus. I'm not going to be the only one. So the system changes. You have to change professional attitudes and behavior, right? Changing behavior is not easy. A lot of things that I like about our work is that we have parallel process. I believe in parallel process. So, we're trying to get people to change behavior, but we're also trying to change behavior. And we don't like to change behavior, our behavior. We don't like it when change comes down, yet we expect our families just to hop to it and change their behavior, right? So there's a disconnect sometimes there. We don't realize that the parallel process is going on. So if it doesn't work with us, it's probably not going to work with them. You got to figure out how to do that. So you got to change the professional attitudes, behavior. You have to change your organizational structure, and that was a big change within DSS with AR. I mean, we went from, having just screen out to either accept an investigation. All of a sudden, we're introducing this tool that has specific questions. It has a risk matrix. You're able to now shoot those families over to some providers that'll be helpful to them. So it's a big change. And getting people to understand how to use the safety questions appropriately, how to use the risk matrix appropriately. We're still struggling with that. Any implementation takes, according to the NERN, it takes 3 to 5 years to really get proficient. So we're in the early stages of learning to be proficient. And some of the questions, I think, point out where we've still got gaps and where we've got to go to make some of these changes. And we're still struggling some with getting this risk matrix exactly right and that kind of stuff, but we're working on all that. And you also have to get your stakeholder relationships, and that was, again, a lot of the questions today. And I think part of Jessica and I presented in Nashville, and one of the things that we have talked about is that we probably did not do as good a job with the stakeholder relationships as we should have as our implementation. In the upstate with the first 3 counties, we went and talked to the judges. I mean, we went to Anderson and Spartanburg and Greenville, and we sat down with the judges and told them what was going on. Some of the county directors went to law enforcement, talked to them, but that didn't happen in all the counties. And that's something that I wish we'd have done a lot better on, and we need to correct that as we go forward. And we didn't work with the schools as well as we should have either, to let schools know what was going on all the time. We as well as some of the other key stakeholders in the system. So That's a lesson that we learned as we moved forward. We did get rolling pretty fast because everybody, once we started in the first 3 counties and they were starting to see some success, all the counties wanted it then. And it is a tribute to both Safi and Growing Home Southeast that they were able to accommodate us as we rolled out a lot faster than we anticipated. So anyway, so then when you do the NERN, you have drivers. You have the leadership drivers, which you have to have the leadership that buys in and wants what change is going to happen. If you don't have the leadership, if y'all have been around a while, you know South Carolina tried to do, and we tried to do this before in a dual track type thing where it was a lot of states use, for their appropriate response, they use the same caseworkers, same folks that are wanting to either respond in a differential type way or more family-friendly way, but then sometimes they do an investigation. And so that sometimes works, sometimes doesn't. So that was probably not a model that we would embrace or your workers would embrace. Some states have been very successful with that, but if you're getting a lot of calls and you're just overwhelmed with cases, then it's not a model that's going to work very successfully. So you have to have, the leadership has to be there to buy in, but they also have to choose the right model that's going to work for South Carolina. And then sometimes you try things and they don't work, and that's part of, I mean, God knows I've learned a lot from trying things and not working and having to get back up. But that was a learning experience for us, that was not the right model to move forward. So then we are able to choose another model and do it a lot more efficiently. You have to have the competency. We've had to, thanks to Teresa Costello that was here, she was gracious to come back many, many times to South Carolina. We've done a lot of training around the state. We continue to do training with our intake workers and all to try to build the competency. I know Safi and Growing Home still continues to work with their folks to build competency so you can get better and better. And as you go forward, you learn things and change things and are able to do that, and your competency gets better as you move forward. So we're, like I said, in our very infant stages of implementation. Jessica and I always joke that it takes 3 to 5 years, but we work in dog years, so it's really 3 or 4 months. And some of this stuff, because we made a lot of changes very quickly. So the one I want to focus in on today, the driver that I'd like to focus in on the most today, is organizational drivers. Okay. So organizational drivers are systemic interventions. You have to have the multi-level alignment, maintaining communication at all levels. So our internal and external collaboration and coordination, that's what we were talking about. That's why we're here today. We're trying to get the message out, find out more about who can work together, what kind of protective factors we can build, how we can create. I mean, I hope out of this meeting today at some level that not only do you connect with each other and but maybe we develop something even new, better. We get together and we say, you know, if we did this, it would be even better than what we got now. So I'm hoping even that as we go forward that we'll keep developing, growing, doing better and better and better. We've got to get our perspectives of our internal and external stakeholders. Like I said, we didn't do that as well. And I don't think that all of our external stakeholders understand their role in the change. I mean, again, that's why we're here, some to help keep getting that message across. And I liked what Keontae said, you know, once you tell one person, tell us some more, let's kind of get the message out and see what we can do. Our facilitative administrative, have to reduce the barriers. Within DSS, of course, there's early adapters that love change. They love what we're doing. There's others that are a little more resistant, and we're working with that to try to figure out what we need to do. There's also some organizational structure that we are looking at to see if we've got the best organizational structure for what we're doing. Just because we've always done it this way doesn't mean we always have to do it this way. We are continually looking at our data to see if the organizational change would help in everything we do. And so there's just as an example, some of the counties, especially the smaller counties that don't have a whole lot of staff, may rotate people through intake. Well, of course, if you're rotating people through intake, you don't get as proficient or as competent with the use of the tool as you would if you did it all the time. So, and you might not know all the questions to ask or not learn those kinds of questions. Oh, I really need to know that. So those kinds of organizational changes or structures are what we're looking at to see if we can define what's the best way to do it. We've had to develop a lot of different policies and procedures. There for a while, we were basically working off our procedure guide that we got from Hawaii that helped us do a lot of this as we were developing policy to match this. We did this a little backwards in our implementation, where we actually implemented and then developed the policy around it instead of developing all kinds of policy and then trying to implement on top of the policy. I like the way we did it a whole lot better, because then your policies are a lot better and match more what you're actually doing instead of trying to fit something in a box that you've written yourself into. We've got some feedback loops. We have, y'all know, we have P2, we have calls that started out as weekly calls with the providers and county offices within the state. And then we've had VCL calls where we've talked about issues going on. So we're trying to create those feedback loops so that as problems arise, that we'll be able to we'll be able to solve those problems quickly, because a lot of times within this big bureaucracy of people, sometimes problems don't get up very quickly, and it's thanks to Jessica and Isabel when she was here. They've been on the calls, they run a lot of the calls, they look at all the data and all that, so that as problems are identified, we can quickly get to be able to change what we need to change. And that's a change within our organization and our structure, to be able to get that kind of buy-in at that level so that we can make those changes quickly. We have a monthly meeting. It seems like sometimes more than that with SAFI, and now I'm also doing that with Growing Homes. And the Growing Homes and SAFI have meetings also with different counties and all that. So there's a lot of communication going on. It's not always pleasant communication, I guess. There's a lot of times people don't agree, and that's good, because that gives you that tension, and that tension is what brings you about better results, better outcomes of what's going on. I think that's been something that we've kind of shied away from a lot of times, is having that tension. So we do need that tension so we can make those changes in a way that gets us a lot better outcomes, instead of just saying we're going to go along to get along and not really making the changes we need to make. So we have that. We have our SACWIS system, our statewide automated system. And like I said, the intake, when it comes in and goes through the portal, goes into the safety questions and the risk matrix. Then there's a decision made, and it's captured. All that information is captured where the case goes. If it's FSS, VCM, all that's captured, or CPS. All that data is captured in that system. Like I said, the portal, all of the assessments they do, all the dictation, everything that the providers do is captured within that intake, so we can look at that. We can always go back and look at that. If there's a new report on that family at any time, we can go back and look at what happened before. So there's a lot of data that's captured. Every time a case comes back, it's captured of why the reason it came back. If it was for like Teresa said, it's voluntary service. So if the family refuses and it comes back, then we've got that. If it's because they got out there, a report is not always a report, is not always a report. One of my favorites was actually in Anderson, where there was supposed to be kids and bloods and guts and everything was awful, and they actually got out there to do an investigation, and this person didn't even have children. So your reports are sometimes really good. Your reports are sometimes not so good. So sometimes you get out there and what was reported is not there. Another one we had was when I was in Greenwood. We actually had one where there was a child that got bored in class and started just taking an eraser and just making marks on her arm just because she was bored. And so when we got out there and figured that out, it wasn't bruises, it was just a bored child. Those kinds of things. We need those reports because we don't know what's going on, but once you get out there and figure it out, you sometimes see that the report is not a report. So then those can come back with us, and we can keep track of that kind of stuff too. If it's a high-risk case, then we keep track of that too. So we've got all this data that we are collecting. Some of our data is based on 6 months, like reabuse rates, things like that are based on 6 months. So we're not going to have good information on some of that probably for another couple of months till we get our full year in and be able to really look back to get a good set of data on some of that. Like I said, the documentation is in the system, and our we've had, Teresa and them did come back and do one fidelity review. We need to do some more, and we did share that with our folks, and then tried to make changes around what needed to happen on some of those things also. I think you're up.
I wanted to talk a little bit about what Steve mentioned on the fidelity review. Not only did we have our NRC partners helping us with that, but we were also doing that internally. We're using the same tool that the NRC developed to review those decisions, if you will, on the front end, and feeding that information back to our staff. You all may know that we had a Child and Family Services Review, PIP, Performance Improvement Plan, that we had 4 innovation counties working under. And one of the things that we learned through that process, because they were reviewed every 3 months, they would have a QA team come in and pull either 20 cases or 40 cases, depending on the size of the county, and write up a report and have a conversation about what they saw in that review. And through that, even though they weren't too excited about it to start with, having somebody come in and review their work every 3 months, now they've talked about what improvement they've made as a result of that feedback. So we're trying to enhance other opportunities for feedback so that we're feeding that information back to our practitioners so they can grow their skills. Just like when you're in school, you have tests along the way, you have quizzes along the way, so that feedback about your work as a professional. Because we are professionals in DSS as well as in the work that you do. So we need to increase that feedback so that we can improve the outcomes in decision making. You all will be hearing some more about some of our WIGs. We've had WIGs for positive permanency and adoptions, and we are doing a quality WIG this time, particularly around item 4, which is a CFSR item 4 on safety decision making. So you'll hear more about that at our next public meeting, P2 usually, Palmetto Power. If you don't attend regularly, our next one is May 31st. Thank you, Tina. So it'll be here in Columbia, and we'll be talking a lot about how you can be a part of helping us improve the quality decision making that we do inside of our system. All right, so we're going to give you a little history about where we were and where we are. In 2010, 2011, as we talked about before, we had two options. You're either in or you're out. The family's bad enough to get in or not quite bad enough. And so we had 63% of our intake calls were investigated or assessed. As you can see, 36% of them, we decided you're not bad enough at intake. No other action. So screen out, no other action. So we did nothing at intake. And as you can see, the indication rate at that time was 38.5%. So of those 63 that we brought into our system for an investigation, we found abuse and neglect 38.5% of the time. So we'd go in to the family and increase the anxiety and stress in that home, and then go, oh, my bad, never mind, you're not bad enough. And we'd walk away. The family would receive nothing other than the increase in anxiety, and we heard this morning about the increase in depression by the mother, and I heard this morning or last night on the radio about how the one thing that mothers, that increases their stress and anxiety is anything about their children. If there is anything that could happen, might happen, or anything involving their children's safety, that immediately causes stress and anxiety and depression. Fathers, for some reason, it's about their ability to financially take care of their family, which that's important too. But we know from the research that Teresa mentioned this morning that it increases the depression and anxiety. So that's what we were doing to families because we had no other option. We were the only thing. We would do investigation, and 38% of the time we'd say, okay, yes, there was something. But what's the math there? 60-some percent, 63% of the time, or 64% of the time, we'd walk away and the family would be no better off, and as a matter of fact, probably worse off as a result of our intervention. So in the upstate region, and we use the upstate region now still because they have had the longest time of implementation. They're the only part of the state that's had more than a year. So this is the regional CPS for upstate region, and this was May 2012 and October of 2012, when we had other opportunities, other things that we could do for the family. So May 2012, now mind you, we had just started in January. So this wasn't a significant period of time, but we also wanted to look at it. Steve mentioned that we have calls. We used to have weekly calls. We've given our county directors and our partners a break. We only do them every other week now. And we do those calls on Fridays at 4 o'clock. Every other Friday at 4 o'clock, we're looking at data. Keontae's on the call with us, and Gail from Growing Home Southeast, and the YAP folks are on the call too. And some of our county directors just absolutely love those Fridays at 4 calls. Yeah, right, Susie? But we do talk about this kind of data. We talk about our distribution. We talk about the fact that we have 21% of our cases going to VCM, which our partners talked about that being that moderate risk. They're not high risk. There's no safety issue, but there's something there that family needs some more intensive work. 21% in May of 2012. 20% FSS, which is the low risk. There's something there that family needs some kind of support. We still have some families that either there's not enough information at intake or it doesn't rise to the level of needing some kind of intervention, 21% of the time. And we were still maintaining, what is that, 38, 35, I can't tell. And I know you all can't see it if I can't. We were still maintaining those for investigation. This was about 4 months in, 3.5, 4 months into the work. As you can see, 10 months or 9 to 10 months in, our distribution changed. It changed to where we were receiving and keeping about 33% for investigation. But the biggest bar that changed was the screen outs, the ones where we decided you don't need anything at all. That's the purple bar up there. It went from 21 to 15. So we were deciding that our partners really needed to provide some additional services to these families that maybe would have received even nothing when we began. So we're still, as Steve mentioned, still in the learning phases of implementation. And we will continue to look at the data, we'll continue to look at how we are improving. And one of the other ways, one of the other indicators that we are doing the right work, as Lillian described earlier, the heart attacks being only us, and the heartburns being somebody that can provide something else, a different level of intervention, is our indication rate. So those that we are investigating now, we're finding abuse and neglect about 45.8, and that number has bounced between 45 and 52 since implementation. Now, we don't have a magic number. We don't have a goal for the indication rate, but we do know that 38% wasn't right. So being in the 50 range is probably better at this point during implementation. We anticipate that it'll grow a little bit more as we become more comfortable with the questions that we ask at the beginning, and we become more proficient at utilizing the tools that we have. So, but again, we don't have a goal because there is no standard on this. There's no benchmark, if you will. Steve did describe that other states do it completely different. We are one of very few states who actually partner with community partners. Most states keep it in-house. They keep it close to the vest. And we, as you know, those of you who've been a part of P2 and other things that we've been doing have been very, very purposeful in putting it out there so that you can be a part of the child welfare system. And so we will continue to do that. We'll continue to keep an eye on our indication rate. And Steve mentioned the repeat maltreatment and the reentry rates, all of those things. We have some data, but not enough to really know whether there's any trends on that. And we will be sharing that as that comes out and becomes available, because some of the families are still being served. So they haven't had their services ended to know whether or not post those services that they've entered back. So that information is yet to come, and we will continue to have feedback about that and learning opportunities for our staff as well as our partners. So this is just kind of a snapshot of more recent distribution and the numbers of cases just in Greenville. We used Greenville County because it is our largest county, and they were one of the first 3 that launched on the same day. And as you can see, the number of cases in 2011 and 2012 were significant. That is a significant number of families who have needs in Greenville County. And we have 45 other counties around the state that have these numbers as well. So if you're in a local county and you want to know how many families are really in need here, your county directors now have access to data that they never had before. As I mentioned, we have those calls every other Friday at 4. We also get weekly push reports so that they know exactly what's happening with the families that they're serving. Every Sunday night around 8 o'clock, we get a push report, a list of about 8 of them that they can use to manage their work. And none of that was used before 2 years ago. So we're creating a demand for our internal staff to know what's happening within their community. So if you want to know that, you can get that information now where you couldn't have gotten it before. So we're continuing to distribute this information, share this information with you all, and want to hear some ideas about how you see yourselves and in your community, maybe some commitments. Steve and I met during Project BEST back in 2007, and one of the things that I found very interesting about Project BEST was they would always ask you at the end of a training, what are you going to do by next Tuesday, right? Every single time you met, what are you personally going to do by next Tuesday? And so I thought we would put that out as a challenge for you all, as something that you know that your community needs, that there's something that you can offer these children and families in your community, and you're going to do that by next Tuesday. And since today is Wednesday, that gives you almost a full week in order to do that. And we would love to hear some of your ideas. If you have them, you want to shout them out on a microphone. We were instructed that if we asked for questions, that we would need to repeat the question, but I'm also asking that if you have a commitment that you'd like this audience to hear about and even hold you accountable for, that you would share that with us this afternoon, and then we'll pass it over to Amy for closing.
And one of our things in accountability is you make a personal choice to rise above your circumstances and to see a problem, own it, and do something about it. So how many of you have seen something in your community and say, somebody should have done something about that, or somebody should do something about that? Well, maybe that somebody is you. So see it, own it, solve it. Rise above, make that personal choice to do that, and do it. Right. So make your commitments, and you got to write down your commitment or tell somebody your commitment, or it's not any good. I mean, you can make a commitment to yourself, and then how many of you committed to lose weight and you didn't tell anybody, and nobody knows if you made it or not? So make your commitment, tell somebody about it, and then if anybody's willing to share, we'd love to hear a few of what we could do, or what we could do, or y'all could do, or together we can do to help make children safer, and safe children, happier families.
Okay, I was just going to say, y'all did a great job. I really enjoyed it. But I teach a children's class at church on Wednesday nights, and I always tell them that. I tell them, go to school. When you go to school tomorrow, see if there's a child that doesn't have any friends or somebody's having a hard time, and go speak to them and help them. I said, when you come back here next Wednesday night, I want to know what you did. Okay. And they see each other at school, so they're like, he really did. I saw him. But that's my thing. I just like this for them to see what's going on so they can help too.
Wonderful. Thank you for sharing that. Raising those next social workers is what you're doing.
Yeah, exactly.
Hi, I'm Ana Isabel Gallego with the PASOS programs. We serve the Latino community in 15 counties, but specifically for parenting classes, we do it here in the Midlands. Our services are free and in Spanish. It's with the PPP curriculum, in case any one of you wants to make a referral. And the thing that we can do is that if we get access to data of where are the cases of Latinos by zip code, we have a promotores program that is working to reduce child abuse and neglect, and we would like to reach that zip code to get a promotor from that place.
Great, I appreciate that, and I think that's something that we're going to have to dive into our data to see whether or not we capture it well enough. We may need to crosswalk that with some other data to make sure we're giving you the right information, but I would love to have your contact information before you go so we can connect that with our county directors as well. Thank you.
And to kind of piggyback on that, when one of our Casey consultant was here last week, we were talking about actually working with some folks, somebody here in South Carolina that used to work with some national folks about data, and they were wanting to look at the same things. Where exactly, I mean, they want to target it down to a building or a neighborhood or anything, and see where those are coming from and what we can do in those communities, those smaller communities even, to start making a difference. So there is a push out there to do that. So yeah, we'll
definitely connect you with our national partners so that you can be a part of that. And maybe it's census tract to be even more specific about what types of areas we want to use, because zip codes can change sometimes, but being able to drill down. So thank you for that. So that's a commitment for us and you.
Right.